All right, well, want to welcome everybody to our first Scholars webinar of 2022 from the Cancer Prevention and Control Research Network, which we call the CPCRN. My name's Daniela Friedman. I am the PI of the CPCRN Collaborating Center here in South Carolina, and I co-chair the CPCRN Scholars Work Group with Con Escoffery, who I just saw, there she is on the screen. Dr. Escoffery is the PI at Emory University. And we truly want to thank our project coordinators who make everything happen, Courtney Patagna and Sam Noblet, who are also on the call. We want to welcome members of our Scholars Work Group, and you all help plan our programs for the scholars. We want to welcome all of our scholars and wish you well, and hope that you are enjoying the materials so far. And we want to welcome our collaborators, our affiliates, and our track leads, and we're very glad that everybody was able to join today. We are recording the seminar, so it will be available, and we will put the link into Trello, which is our favorite platform for placing all of our CPCRN materials. Stay tuned for other webinars as well, and I know that we will be meeting in groups, our groups of scholars coming up soon, and we want to get your input on ideas for future webinars. So we look forward to speaking with you all soon beyond this webinar. All right, I am thrilled. We have two fantastic panelists and experts in cancer prevention and control and implementation science joining us today. First, I'd like to welcome Dr. Cindy Thompson at the University of Arizona. Dr. Thompson is the Arizona CPCRN Principal Investigator. She leads a multidisciplinary research program in cancer prevention research that focuses on lifestyle behaviors, cancer prevention, and survivorship. She is also the co-lead of the survivorship work group for the CPCRN. Dr. Thompson's translational research program integrates novel interventions, including mobile health technologies and delivery systems, as well as behavioral theory and cancer-relevant biomarker research to advance our understanding of optimal health behaviors to improve health after a cancer diagnosis. Her research predominantly focuses on obesity-related cancers, breast, ovarian, and colorectal cancer, and includes dissemination and implementation science, which we often refer to as D&I, to expand the impact of her evidence-based research. Welcome, Dr. Thompson. Thank you for being here. Also want to welcome Dr. Mary Charlton from University of Iowa College of Public Health. Dr. Charlton is an epidemiologist and a health services researcher who is affiliated with the CPCRN in Iowa, and she is also the director and principal investigator of the statewide Iowa Cancer Registry. Dr. Charlton has conducted numerous studies of cancer risk factors, outcomes, and disparities in access and quality of cancer care, and was recently awarded an NCI-funded R01 focusing on improving access to high-quality cancer care for rural patients. And we can't wait to hear more about her work. Welcome, Dr. Charlton. So the plan for today is each of our panelists will present for 10 to 15 minutes about one or more of their implementation projects. They will present some slides, and then we're going to open it up for questions. I have a few questions. I could ask questions all day, but we do want to make sure that we have time for everybody to ask their question. You can put your hand up in Zoom after, or we can include the question in chat, and we'll be monitoring it. So I'm going to go on mute and turn it over to Dr. Thompson. Thank you for presenting your work today.
All right, would help if I unmute for sure. Thank you so much for the opportunity to speak today. As you can see, I titled this The Good, the Bad, and the Ugly, because I think that one of the things I've learned as I've moved into D&I science is that the real world matters, and sometimes it catches you off guard. And some of the other individuals on the call today, like Melissa and Emmanuel, you can weigh in too if you wish. But what I wanted to do was share with you one project, and I'm going to whip through these slides because 10 minutes will go fast if they'll move forward. There we go. So the catchment area for our cancer center is the 5 southern counties, 4 of which are on the border with Mexico. And just to give you some context, our catchment counties range from 30 to 84% Hispanic. The 84% is Santa Cruz County, which is the county that we operationalize this project that I'm going to talk to you about. It's also a county with a younger mean age and also a high level of poverty. About 24% of individuals are living in poverty, and about 14% are uninsured. So just to give you some context in terms of what Santa Cruz County is about. If you look at the screening rates in this area, one of the things that is clear across Arizona, but in each of our counties of the catchment, is we underperform when it comes to colorectal cancer screening. And you can see that the US average here in green, and the state driven by Phoenix and Tucson, which are more highly educated and have more access to care, do okay, but these southern counties are not doing well. And Santa Cruz County, as you can see, is about 49% are meeting the screening rates. And these are even lower than what we see for cervical and breast cancer, of course, because I think with our cervical and breast, we have the CDC programming that's really increased screening. So we were in regular meetings with Mariposa Community Health Center, who is our partner on our CPCRN project, decided that we might have an opportunity with the flu vaccine clinics and with the COVID vaccine clinics to try and advance the FluFit program in Mariposa County and improve our colorectal cancer screening rates. And remember, excuse me, this Fit Flu program is an evidence-based intervention. If you go to the NCI EBCCP list of programs, you'll see this program was designed for the age group that we talked about, 40 to 65. It has high research integrity at 4.7 on a 5-point scale. It has high dissemination capacity. And if you look at the REAIM scores in terms of its reach and effectiveness and adoption, it scores very well. And so we clearly were on target in terms of using this FluFit program as the basis for our work. If you look at what the program is, I'm not going to spend a lot of time on this. Most of you probably know about this, but basically what we're trying to do is offer people the FIT kit or the FOBT kit when they come in for their annual flu shot. And in Mariposa, what was happening was there was a decision to go ahead with the flu shot clinic, and it was very community-based. They opened up a community center, posted signs in Nogales, Arizona, and invited people to come. They also advertised it through the Mariposa FQHC. And the idea was to give people who were eligible the FIT kit at the time they came in for their flu or COVID vaccine. They could get both or either at this clinic, and then to follow up with them. In terms of, the actual program, we obviously pulled together a team that included stakeholders from Mariposa, both in terms of their community groups, community health workers, as well as their clinical staff, in addition to the Arizona individuals, and, trained them up, did a training for the community health workers, and talked about how to organize workflows. So we did follow these steps. And we also looked at the steps to adaptation that have been published in the literature in terms of assessing the community need, selecting what intervention we wanted to use, engaging stakeholders. I might mention ACS Phoenix or Arizona was also actively engaged in this project. We talked about what might need to be adapted. Obviously, 80% plus are speaking Spanish in their homes. So that was a major adaptation that was absolutely essential. And then we set up the training, completed training with community health workers, as well as the public health students and related interns that were involved from the UA side to implement and then evaluate. And so I'm not going to have time to go through all the input and activities and outputs, but you can look at these. Our goal was to increase the knowledge of the community health workers at the short run, but then also obviously to increase colorectal cancer screening in this community. And we developed a process map in which we evaluated their eligibility and then put them through the steps of getting a fit kit and having follow-up. Now, one of the things that we were interested in was we had previously identified that maybe one of the barriers for processing the fit kits and getting these rates up was the fact that people are doing these at home, and are they getting back to us? And the data suggested they weren't. And so we wanted to move beyond mailing, because we realized that for some of the feedback from the community was that they were not comfortable mailing their bowel movement sample. And so they would rather drop it off. But we thought, well, maybe if we gave them the option of the community health worker coming by and grabbing it from their home, that might enhance uptake and complete the circle of screening that we were trying to achieve. So that was the process. We developed scripts for the individual community health workers to follow up once people were provided the kit at the screening event and the flu shot event. And so those are in here for you, and tried to, in the process, collect any additional barriers that we may have missed earlier in our work. And then we wanted to make sure that we were recording in the records what the follow-up was. So what went right? We got a lot of buy-in. We did an effective community health worker training that increased their knowledge around colorectal cancer screening. We had a very short window because in COVID times, right? Everything was like, should we do vaccines? Should we not? Should we do flu? Should we do COVID? Should we do them together? And so while everyone was revved up over the summer, it was like all of a sudden Mariposa reached out to us and said, we're going to do our first one in 2.5 weeks. Can you staff it? Can you help us? Can we get this off the ground? So, we did have a rapid response. We got educational materials adapted and ready. We got good enrollment in terms of people coming through the clinic. In the first 2 days, we had about 58 people that we provided kits to per day. But what happened, surprise, surprise, was that while we had the clinical team at the table when we were doing these processes over the summer and working this through, when it came time for the clinic, they were highly engaged in the vaccination, and their ability to do sufficient eligibility screening in terms of whether people were Mariposa patients was in afterthought was inadequate. And when you have a community like Nogales and you ask people if they're a Mariposa patient, basically what we realized is that everyone feels they're a Mariposa patient, whether they actively are at this point in their life or not. It's part of their community, and they see themselves as Mariposa patients. And so a number of people brought their kits in and were not in the Mariposa patient registry. And so all of a sudden we had fit kits that we were unable to link to a provider to get processed. And so you can imagine this was rather disastrous. And, you know, the good news is it was 2 days before people were bringing back their kits so fast that we were able to catch this early on and shut it down. But unfortunate. So what are we doing now? We've had a stakeholder discussion and kind of talking about, you know, the fact that we really have to engage the clinical stakeholders at a much higher level through the entire process. We've decided in the meantime that one place we can have an impact that requires less from the clinical stakeholders is to focus a program on prediabetes and diabetes and individuals who are considered at higher risk for colorectal cancer, and link this to the existing diabetes education program at the FQHC. And so we're currently in the process of doing that, starting again with some focus groups among people with diabetes, and then we'll revisit the Fit Flu idea for fall, hopefully post-COVID, but we may still have boosters for COVID. And that is it. Excuse me, I'm getting over bronchitis, so. Daniela, do you want to take questions now or should we wait till the end?
Well, first, thank you so much for sharing. I think what we'll do is Dr. Charlton will present next, and then we'll have questions after that. So if everyone can save your questions, make some notes, start typing them in the chat, and then we will open it up afterwards. I think there'll be, there might be some questions that will be for both of you that I can see some folks ask. So thank you so much for sharing that. And now we're going to turn it over to Dr. Charlton.
Okay.
Excellent.
You see that okay?
Beautiful. Thank you.
Okay. With these old school slide templates, we don't even like support these anymore. I don't know. I keep building off this one, but anyway, Mary Charlton, and I'm at the University of Iowa, and like in my introduction, I'm also the PI of the Iowa Cancer Registry, which is how I sort of stumbled into this project. I wish I was an expert on implementation science, but I'm learning it as I go. So have to maybe bear with me, but I'm happy to answer any questions. But I enlisted the help of Sarah Birkin, who is a wonderful expert in implementation science. So she's kind of my partner in crime with this grant that I'm going to talk about. And I've been really fortunate to have her as an implementation science mentor through this. So I didn't start small. I didn't start with a nice small type of implementation science project. I started with a big kind of ugly, hairy system level intervention that was designed to improve the quality of cancer care for rural underserved patients. And that's what I'm going to talk about today. As I'm sure most of you know, rural patients experience significant barriers to accessing cancer care and experience worse cancer mortality than urban patients, even though they have similar, if not even a little bit less, lower cancer incidence. And community hospitals in rural areas play a crucial role in providing care to many patients who otherwise would not have access. But these hospitals typically face barriers to providing comprehensive care due to lack of resources. So maybe in an ideal world where we could, get everybody shipped off to a large academic medical center for their cancer care, it's just not the reality of the situation in most rural areas. And a lot of people really want to stay close to home where their social support network is, where their resources are. But I noticed in my role with the Cancer Registry, we have 118 hospitals in Iowa, and only 10 are what's accredited by the American College of Surgeons Commission on Cancer. And if any of you are at large academic medical centers that have a cancer center, chances are they are accredited. Most large urban cancer centers are, but not very many rural ones are. And I always wondered from a cancer registry standpoint, we would have field staff in those hospitals collecting data, and no one ever asked for it. I don't know if they didn't quite really know what we were in there doing, or nowadays we just remote into their records and can get the information. But I was always stumped, like, how did they know how they were doing if we were collecting the data and they were never asking for it. So started along some projects of where I thought maybe we should be giving that data back, and working with these hospitals, started to get to talk to a lot of them and understand some of their challenges and barriers. And was trying to figure out what could be done about it when I went to, I think it was the first sort of conference that NCI held specifically on rural cancer challenges, I think back in maybe 2018. And I heard a speaker there. His name was Tim Mullett, and he was a thoracic surgeon from the University of Kentucky Marquis Cancer Center Affiliate Network. And they were using evidence-based standards developed by the American College of Surgeons Commission on Cancer as a framework to support these sort of community hospitals that became affiliates with them to improve the quality of their cancer care. And these weren't like part of the UK system or anything. These were just community hospitals where there was no formal relationship, and they were going out and working with them to help them improve their quality of care by helping them achieve the standard, these evidence-based standards of the Commission on Cancer. And as far as we could tell, when we went to visit them just before COVID, to kind of figure out how they were doing that. And so from what we could tell in some interviews that we did, we could see that they were using the expertise and the resources at the University of Kentucky to help these community hospitals develop programs and resources that were tailored to the needs of those hospitals. They're supporting the infrastructure for data collection and reporting. They're providing consultative expertise and mentoring for clinical champions and for the administrators also. And they're providing guidance and templates for meeting these COC standards. There's like 27 of them. It's pretty onerous to document that you're doing these different things like tumor boards, and that you have a cancer committee, and that you're offering nutritional support and psychosocial support and survivorship care and all these different things. And they have very specific ways that you have to document that. And so they're making it so that each hospital didn't have to figure that out on their own. They're sharing templates with them, and here's how we did it. And as they added these affiliate hospitals, they said, well, this hospital is about your size, and this is how they were able to do that. And why don't you talk to them and get some ideas from them about how you could do this standard here? So nobody really felt like they were in it alone. And they assisted with QI initiatives in terms of like identifying good quality QI projects, and then helping with the evaluation, and then just helping them maintain accreditation once they were able to get it. So it was really interesting to learn how they were doing that. We were just kind of blown away by what they were able to accomplish, but that up until we kind of started studying it, they had never published on it. It wasn't rigorously defined, evaluated, or tested in any other setting. So we were really fortunate to be able to get one of the NCI R01s that were specific to rural cancer, improving the care access and quality of rural cancer care. And so in this grant that I have with Sarah Birkin, we started off needing to determine the core functions of that McCann, that Marquis Cancer Center Affiliate Network model from Kentucky, and document the specific strategies or activities that we could adapt to the Iowa context to carry out the core functions. And then conduct a hybrid effectiveness implementation study that includes a single arm health system intervention trial designed to evaluate the impact of what we're calling ICANN, not very creative, but it had a nice ring to it when we swapped out Iowa for Marquis, on cancer care quality measures and implementation outcomes. So just to show a quick map of Iowa here and our partners, if you can see my cursor, but the orange hospitals are our partners in this intervention. And then the blue hospitals will kind of serve as the control group when we assess some quality measures at the end of this using Iowa Cancer Registry data. And so these are kind of, they're all different sizes, but I would say the smallest one probably sees about maybe 350 newly diagnosed cancer patients per year. And some of them, like this one down here, is a little bit bigger, and they see several hundred cancer patients a year. And you can see they're technically in non-metro areas and sort of a lot of rural patients. And so before the grant, we kind of pitched, here's our idea, here's what we'd like to do. You certainly don't have to sign in blood that you're going to go all the way to this accreditation or anything, but can you work with us to see how far we can help you get, and just do some assessments and some interviews with you. And they were all fortunately very good sports and gave us letters of support. And then since we visited these all, my very first trip after or during COVID, I guess, after it was subsiding a little bit here, was to Carroll, Iowa, a few hours away. But we've been able to make the rounds to all these orange hospitals now to kind of talk with them, talk with their leadership, their clinicians. And now we're in a phase where we're doing some gap analyses to say, here's where you are and here's where you need to be in order to meet these standards of the Commission on Cancer. So we're kind of over here in this figure. We're still in AIM-1, where we're trying to adapt this model to rural hospitals in Iowa. And so again, we did some interviews with those affiliate hospitals down in Kentucky and with the McCann leadership and staff. And now we're kind of in the process of doing more interviews with the Iowa hospitals to try and see, like, well, what can we adapt? Like, what won't work that they were doing in Kentucky without compromising on any of those core functions that we were able to identify. So we're still in that process. And then we will implement this intervention. Again, like I said, we're kind of getting a jump start on conducting gap analyses and needs assessments. And so we have a support team for each of the components of a cancer program. We have people who can help with data collection and reporting, administrative leadership and staff support. And then it's really important that those programs have a physician champion and clinical support for that. Because really, without having a strong physician champion at a lot of these small to mid-sized hospitals, you can imagine it just wouldn't work. And then we move into evaluating implementation determinants and outcomes, and then evaluating the clinical effectiveness, again, through measuring the cancer care quality measures in the hospitals that participated and in those who are of similar size and characteristics but did not participate. So just to kind of recap again, I've talked through a little of this already on AIM-1, but we did interviews with Kentucky hospitals. We're at the point where we've identified the core functions and then presented those back to the McCann leadership to see if it resonated with them, and kind of went back and forth with them a little bit, and then really tried to characterize, what is the setting in Kentucky? And it has a lot of similarities to Iowa. It's mostly rural, mostly white, similar number of hospitals. They have a little bit more of larger hospital systems and for-profit hospitals than we do. One kind of funny thing that we learned when we were there visiting, I don't know what the cancer centers are like in your respective areas, but we were kind of stunned, like that name, that Marquee Cancer Center Affiliate Network, that Marquee, everybody knows that name, like the different hospitals we talk to and the different people, they say it. There's so much respect for Marquee that we really wanted to be affiliated with that program. We really wanted to work with them. It helps our patients know that they are going to get standard of care if we're working with Marquee. And that's not really the situation in Iowa. We're kind of skewed to the eastern part of the state. Let me just go back to that map. We're over here. So we're not really in the middle. And there's other academic medical centers over here in Omaha. Mayo is up here, South Dakota, Wisconsin, like so. And then we have a lot of large cancer center, or not a lot, two large cancer centers in Des Moines, right in the middle of the state. So we're not quite the central hub that this University of Kentucky Marquee Cancer Center is. And so there might be some adaptations we're going to have to make around that. Everybody really loves Kentucky's basketball team. They were like a state united behind this basketball team. We have a couple different universities at Iowa. So if you're an Iowa State fan, you really don't like the University of Iowa very much. There's just a different vibe, and just some other more concrete, tangible differences between the two that we really kind of have to figure out. How will that affect the activities then that we do underneath those core functions to pull those off? And so that's what we're trying to figure out with these interviews with Iowa hospitals, administrators and clinicians, and characterize the context in Iowa hospitals, and then again, that gap analysis to figure out where they're at and where they need to be. And then once we have those results, we're going to move forward, and we're sort of compiling activities and some of the things that they did at Kentucky. These are just some examples where focusing on educational opportunities, academic detailing, and peer-to-peer support. and structural support and direct services that kind of cross between administrators, physicians, and data collection and reporting staff. And then we'll also, when all is said and done and we've implemented this, we will use the CPCRN kind of structure to understand determinants of ICANN's implementation in terms of inner setting, outer setting, characteristics of individuals involved with the implementation. And then also Proctor's framework to evaluate outcomes of ICANN's implementation, like acceptability, adoption, and appropriateness. And then we will use Iowa Cancer Registry data to calculate compliance with those established Commission on Cancer performance or quality measures. This diagram just shows that the hospitals were pretty similar on these measures at baseline. They were not significantly different. And if anything, sometimes the hospitals that will be participating in this were actually doing worse. So that's kind of our baseline. We're also going to track costs to rural hospitals to pursue those accreditation standards and see how many of those COC standards we can help them meet by the end. And through preliminary interviews with Kentucky affiliate hospitals, we found that that model has resulted in increased referrals for the University of Kentucky and increased market share for affiliates, because they say instead of going maybe to a regional center, because they knew they were affiliated with the University of Kentucky, people were more comfortable staying at home. So that was really a good incentive on both sides. It was kind of a win-win. Kentucky was getting more of the complex referrals, and then the more common cancers were able to stay closer to home. So evaluating these and other potential benefits will assist in strengthening the sustainability of this intervention. And we're also working with the Commission on Cancer itself on developing a distinct accreditation process for rural hospitals. So they're using this grant as an opportunity to really learn about the barriers and challenges at rural hospitals and how they can make this more feasible for those hospitals without sort of diluting their standards that they think are really important and are based on evidence. That's all I got.
Thank you so much. Fantastic. I know it's always helpful for me to hear about a project from beginning to end, or where, how a project is conceived and where it's going. So hopefully this is also helpful for our scholars who are here today. And I know you're going to get lots of good questions. So thank you both very much. I wanted, if it's okay with everyone, to start with a couple of questions. And we know, and hopefully everybody knows by now, even if we're new to implementation science, this kind of work does not happen in isolation. Sitting in our office, one person, this is implementation science. All D&I work is really collaborative and involves partners and stakeholders. And you both mentioned a variety of partners and stakeholders. And I'm just wondering, it sounds like in some cases you had those partnerships beforehand, potentially from other projects, but then when you're expanding to new places, new sites, it may involve developing new partnerships. So can you just kind of describe a little bit how the stakeholders were involved in your work? Did they help, in some cases conceptually from the beginning, or maybe you were already linked with them, like ACS, for example, so that's not needed every time. Just thinking about the hospitals also that were involved with the project that Mary said. So I wonder if you can each just talk a little bit more about the stakeholder role for each of these initiatives. Cindy, do you want to start?
Sure. As you know, stakeholders are imperative. And I think one of the things I've learned in D&I science is sometimes you don't know what you don't know. Like, you don't realize that there are stakeholders that you could have brought in that may have changed things. Or as in our case, I think we felt like we had the clinical team engaged. We had the head of the clinic, we had the nurses. They met with us actually we were meeting like 2 or 3 times a week for a while to get this all laid out in terms of what we were going to do. But at the end of the day, they clearly didn't have the level of commitment that the community health workers. And one of the things that I learned, and I might call out Maya Ingram, who's worked in this community for a long time, and she said, Cindy, this is a recurring issue that we see in the community, in the FQHCs, where the clinical support stakeholders and the community stakeholders don't always communicate. You get the perception that they're working very collaboratively on everything that happens at that FQHC, but in reality, they have very different priorities. They have very different workloads, and I think for me, I feel like we had the stakeholders at the table, but they weren't all engaged at an equal level.
That's really interesting. We've had some discussions lately on how to develop councils, like advisory councils, and how to include different groups within one council. Does it make sense for some projects and not others? So, you know, what you just said resonated with me, because that's come up in some other discussions. Thank you. Mary, did you want to share a bit about how the stakeholders were involved? I know it's a different project, but I think similar question. Yeah.
Yeah, I think just through, you know, just lots of projects that involved rural Iowa, and really being active with our state's cancer consortium has been huge for me. You can almost always find somebody that has a connection. That's one degree of separation from the place I need to get. The cancer consortium has been great. My partners have been great. One of my collaborators, her name is Ingrid Lizaraga, and she's a breast surgeon, a very specialized breast surgeon at the university, but she started off as a general surgeon in one of those hospitals that we're working with. So she could really understand kind of where they're coming from and their challenges. And so it comes across as very sincere. And from the very beginning, we're like, here's the deal. We cannot come in from the University of Iowa, like we know better than they do. Like we cannot come in and say, we're here to tell you how you need to do things and that type of thing. So what we still to this day have to check ourselves and be very careful is to say, you know, we can't believe basically like how great you're doing. You have a fraction of the resources of larger cancer centers, and somehow by all these relationships you have and just sort of the power of rural, we talk about it like it's a bad thing sometimes, but just like the connections and the work ethic and the trust and everything, to really actually leverage that, to say like, you're doing amazing things already. We're here to help you like show how good you're doing. You don't have a good way of showing that right now. And we can give you some resources that you might not regularly have. And we want to learn from you about how we can make this easier for other hospitals. So we just had to be real careful about how we approach them, because again, I think University of Iowa has a good reputation in our state and our cancer center, but not to the point where everybody would just be like, oh, yay, you're here to help us. So we had to be really careful about that. And then the other thing that I sort of like the trick up my sleeve that I had was my role in the registry, which I can't say enough about how the power of data. I could come in with reports that they've never seen before. So I could start the conversation with, here's what I have for you. And let's talk about how all this is working for you. And it just got them talking without, you know, us kind of grilling them about what do they have, what don't they have. It's like, oh, it looks like you're doing really well in this. And wow, you see a lot of patients with this type of cancer. And then they just sort of start sharing about the things they were proud of and the things that they were doing. And so coming with something in hand for them that we could offer them, I think was a huge, huge benefit to starting off our relationship on the right foot.
That's great. That's really helpful. I think about, you know, we can't talk about going into communities or going into partnerships with saying this is what we think we're going to get out of it. Nothing like that is should not be part of any of our work. And I you know, what you said made me think about how we even frame what we do. And so, you know, for some partners, they're using QI, quality improvement. For some, you know, people may be saying, you know, research. Some people may be saying evaluation. So I think making sure that the nomenclature also fits with what we're doing and that it makes sense for all partners will be important. So that's very helpful. Com has included a note here. I agree, excellent. So thinking about collaborations with state cancer plans and committees and how that can really lead to fruitful collaborations. Com, I don't know if you wanted to say anything about that. I think that's a great comment and a good point.
No, the only thing I would say is for those of you as Daniela mentioned in the team science and wanting to work with communities and health systems or even public health agencies or organizations. I think some of the best ways is to kind of start building those relationships, not even when a grant is not in the picture, so that you get to know folks, whether it's sitting on your HPV, committee, or colorectal cancer. We have a colorectal cancer roundtable here in Georgia, and just getting to know folks. And then when you are looking for those pilot awards or bigger grants, it's easier to do that ask. And actually you already have a support structure around you. So I really like, Mary, that you mentioned that as being engaged.
That's a great point. And you often don't have a lot of time to turn around some grant proposals or concept papers when you're looking for funding to continue on with some D&I projects. So having those partnerships in place up front is really helpful. I remember when I started out starting to do things like that and I was joining our state cancer alliance calls before there was Zoom, and we would actually just have teleconference. You would dial a number and everybody would just talk on the phone, and everybody was talking at once because you never knew who was about to talk. So back in the day. So excellent. I want to make sure if people have questions, feel free to type in the chat. I wanted to ask about evaluation, and I used that word and was also used previously, and thinking about, there were, time points in how you developed your project for when, data might be collected that you would consider the data for how to evaluate what's going well. And I loved, Cindy, how you had said, you called it the good, the bad, and the ugly. What goes well, what doesn't go well, and thinking about specifically around the evaluation. How do you all decide when and what needs to happen for the evaluation? Like, you don't want to go full force into a huge implementation without seeing, is this actually going to work? Which places, which hospitals, which partners, right? So you sort of need to evaluate along the way, but then how much do you do? Because you don't want that to hold you up so that you're taking all of the time doing that and then the implementation doesn't happen. So what would you share with our scholars of, how do you decide which points in time where it's, most important to be collecting that sort of data?
Well, I would just say that, historically, when I heard the word logic model, I went, but now I see the value of it, right? Because it really makes you be thoughtful about what you want to accomplish short-term, intermediate, and long-term. And again, I think it's like our grants. You don't want to invite the evaluation people to the table at the end and say, we have all these data, help us figure out what we did. You really have to have the end in mind from the beginning, and it needs to be driven by your partners and your stakeholders. For Mariposa, they have their CDC metrics that they need to meet, right? And so that for them was the major driver. They also expressed to us the desire to have their community health workers kind of up to date on the most current screening guidelines, because ACS lowered the age, and so we saw a difference in the screening age that they wanted to make sure was addressed. And then we wanted to look at the difference between drop off of kits and community health worker, and just like, do people even want community health workers to come? So those seem like really easy data that we could collect without and integrate into their workflow without creating a whole bunch of new data spreadsheets that they have to, work with. So I think there's a number of things that come into play when we think about evaluation.
Mary, did you want to add to that?
I don't have a lot to add to that. I mean, I think we just planned it out as best we could when we thought it would make sense. But this, our hospitals are going to be going at different paces, and they have different levels of motivation and incentives to do this. So I think we're going to be flexible. I mean, I have to admit, we can't even all agree and decide, when does the intervention start? Like, what is the start point? Because we're doing these gap analyses and trying to say, okay, here's what you need to do. Then what's that date, or what's that thing that makes it, that kicks it off and makes it start? So we're still actually kind of grappling with those questions about when the ideal time is to do those things, but we know the type of information we want to collect, and we're just going to keep meeting and make sure communication is like just the key to this whole thing. And I think I saw somebody else in the chat saying, how do you protect against burnout too? Like all of that, I think for us is communication. Like we make sure nobody feels like they're in it alone. And again, the clinicians have clinician support, and the administrators have administrative support, and those people doing the data collection have a contact who's also doing that. So everybody feels like they're not just being asked to do this really hard thing in their resource, like low resource type of facilities, and that we're just here to keep giving them whatever they need. But that's a huge concern, I think, is that they'll just, with all the other competing demands going on, that they'll give up. So we just keep constant communication, and we drive 4 hours there and back in a day, and we just keep communicating, so we know when the right time is to do the evaluation and keep people engaged and try and keep them from being burned out.
Communication is definitely key. We have great questions in the chat, and I saw you went to the second one first and started addressing it. So maybe we can continue on. I know showing that how this can fit within the workflow, that, trying to make it part of what will continue with standard operating procedures. I know people use that term. There's other terms too. That's a great question. And Mary already started answering that. Cindy, did you want to add anything around, with what we're trying to do with the partnerships, with the implementation within clinics, other clinical type settings, how to protect against the burnout piece?
Yeah, I mean, I think the burnout has been so real during COVID in particular, and it's ongoing because it's going to take people a while to recuperate, even when things settle. I think it has to be linked to what they want to achieve. If we're trying to get an outcome that's important to us, then we're probably not going to get buy-in, and there's probably going to be higher clinical burnout. And so I think if we can get them engaged from the beginning, and they're telling us what their priorities are, and we use that to drive our work, that helps tremendously. But in our case, it was clear the clinical people got overwhelmed with the number of vaccines, flu and COVID. And so we had to shut it down in order to not increase the clinical burden and cause more problems while we were trying to solve problems.
Yeah. So you were evaluating as you went, and sometimes more informally that, okay, let's quickly have an email or a call that this may not be the time to be going full force with the vaccines when there's other things going on, and how can we direct people to get that need met somewhere else? Okay, it's
hard because you have your blinders on, you want to get your project done, and all of a sudden it's been kicked to the curbside. And like in our case, we had students who were doing internships and honors thesis, and you're like, oh my God, they have to be able to do something. So and you can't go to the FQHC and say, oh, our honors intern needs project.
It's tricky. Okay, we have a couple of, so hopefully that answered that question. I appreciate your input on that. We have a couple more questions here, and back to our theme here on partnership. How do you manage accountability? Sometimes it feels like they're doing us a favor. I think that gets back to the win-win, making sure everybody has a role and that everyone is benefiting. That was the first part of the question. And then so let's start there. And then there's another question about letters of support and what they should include when it comes to partners providing letters. Let's start with the accountability piece. I think that sort of evolves over time with how, when you start a new partnership and figuring out, what is everybody bringing to the table? It might take some time. How have it sounds like communication may be a key piece to that. Other things that you can both think of to answer that question?
Well, I think it's the communication and the trust building, but also if you're operating from a logic model where you've kind of had shared governance on what you're trying to achieve, you can revisit those and go, we established these at the beginning. Are they still valid? Do we still want to move in this direction? Do we still want to measure X, Y, Z? And that way it's not like you deciding, it's more, let's go back to the model that we co-built and
Good.
see if we're in the right place.
That's good. So you don't go anymore when someone recommends a logic model. So that's sort of your plan, your contract in a sense of this is what we came up with together. Let's see how we can move forward together, guided by that. That's great. Mary? Yeah.
I think just beyond what's already been said, we try to pay them for their time, try to make sure that we're compensating them adequately for what they're doing and that we're not taking that for granted, constantly being super thankful to them in every way that we can. We end up kind of doing weird just to build the trust and the relationship, like somebody from one of those hospitals, like somebody on our board got referred to the university and they haven't heard back on the referral. Can you track that down? Okay. So then you just start calling, all right, where is this person? Where's Sister Agnes? They need to know where a referral is, or they need data on something, or they want to be part of something and they need something from it. We just try to bend over backwards all the time. Like, how can we, even if it's not even related to this project, what can we do for you? We formed like a rural work group within our state's cancer consortium so that we're kind of pulling more people in and their partners, like the people that refer to them, and try to get them all in. Like, we're just constantly trying to build things for them or the things that they've said would be helpful, even if it's not even related to the project. And I think that's gone a long way in our relationship building, but mostly back to just always showing them, this is what's in it for you. This is why you would do, don't do it for us, do it because you're excited about it for your cancer program. So
Mary, thinking about, you all just got this grant and maybe, there's going to be the follow-up, there likely will be. What are the kinds of things that the partners would include in the letter of support if it's a new partnership? And I think that's what, Rogelio, you were getting at. If it's sort of a new partnership, you may not have worked together, is it strong enough to say this is our potential of what, is that what you were getting at? Okay. What would that look like? What would you ask people, even you come up with a template, and what would that look like?
Yeah, I definitely wrote all those myself. I don't ever ask them to write a word. They're welcome to change it in any way they want.
Right,
the entire thing myself, so that they do very much. And I do try to talk about, we did work together on this project, or we have some kind of history together, but sometimes you just don't. So just say that that we've been discussing this project and that they're excited about the opportunity to like whatever you can get them to say that they're comfortable with. And I'd be happy to just provide that, like the letters that we have. I was trying to pull one up quick when I saw that question, but I always be happy to provide examples to people. You don't want to commit, like make it sound like you're making them commit to this huge thing, but that they're just committed to trying. They're just have an open mind and they're really interested in this. And this is something they've been thinking about and they're excited to learn more about it and to have these resources and that type of thing.
Yeah. And sometimes it may be showing how the vision and the goals align, that maybe we have not worked together. And I know that's, what Mary had said also, but just say, we haven't worked with this academic partner before, but here with our institution, we value the same kinds of things and, the importance of getting evidence-based information to community members. And so it's showing how organizations can align together too. I am mindful that we have 2 minutes left. We could have another hour and I could probably ask more questions and we could ask more questions to get more in depth about the actual implementation. I know we're going to be talking with our scholars in smaller groups over the next little while, so we are looking forward to that. Before we wrap up though, I wanted to ask Dr. Thompson and Dr. Charlton in 30 seconds or less, what is one tip that you would provide to our scholars, anybody on this call, our partners, other CPCRN members, if you are about to get involved in your first DNI project, what would be the one big tip that you would recommend to everyone on this call?
I would say build on existing partnerships. I think that's critical, and be flexible. I think as researchers, we tend to be very sometimes anal in how we approach the world and very analytical. So what I've learned is I need to be extremely flexible.
Excellent. Thank you.
I agree with that. I'd say, don't be a hero. Like up until this project, most of my projects, people were nice, neat numbers in my computer. I had no idea, but I partnered with like the most amazing people through networks like CPCRN. And to have access to that type of expertise has like grown my career and just sort of grown my brain beyond where I thought it could have gone, to actually like fixing things. I was really good at saying what the problem was. I wasn't very good at saying why it was happening and how to fix it. And just partnerships through people I've met through networks like CPCRN, you can really reach to places you didn't think you could go, and you don't have to do it by yourself, and you shouldn't. And it's more fun when you're working with people from different backgrounds. And so I think it's been great. It's really hard, but I've had a lot of fun.
I think that is an excellent place to wrap this up. I think that was a wonderful plug for collaboration, for being flexible, pragmatic when it comes to implementation science, and to build on existing partnerships. And we also talked about communication and trust. So I think some key themes from today. Please join me in thanking Dr. Charlton and Dr. Thompson for sharing their time and expertise and current project with us. Really fascinating work. We're so grateful that you joined us today, and we really appreciate you taking the time. Thanks to everybody who attended, who asked questions. Please let your friends and professional networks know about CPCRN and the Scholars Program, and we will get the recording to all of the scholars and those who weren't able to attend today. So stay tuned for more, and we appreciate everybody being able to join. I hope you don't get as much snow as you're thinking you'll get. If you're about to get snow, enjoy the warm weather without the pollen while you can, for those who are in warm climate. So thanks to everybody. And as always, thanks to Sam and Courtney for organizing our work group and activities so well.
Thank you.
Take care.
Thank you.
Bye, everybody.